Hello, everyone. My name is Jim Douketis, and on behalf of my co-chair, Dr. Vicky Tagalakis, and our panel, Dr. Jay Easaw and Alison Bond, it's my pleasure to welcome each and every one of you to today's educational program on knowledge gaps in thrombosis. So this is a virtual roundtable, and what that means is that we're meant to have a very informal discussion about areas in thrombosis that are kind of in between the lines, off the beaten path, but most importantly, opportunities for you, the audience, to share with us your questions and comments about the areas of thrombosis. So it's meant to be very interactive and literally meant to be, we're all gathered around a round table and having discussions that are case-based. Next slide, please. This educational program was developed by a multidisciplinary committee that included internists, medical oncologists, hospital-based pharmacists, and hematologists. So we want to share with you different perspectives on some of these questions that you, the audience, are giving for us to discuss. So we hope you will appreciate that varied and diverse views on these topics. Next slide, please. Today's panel consists of myself. I'm an internist at McMaster in Hamilton, and my co-chair, Dr. Vicky Tagalakis, also an internist at McGill. We're delighted to have joining us this evening Alison Bond, a hospital-based pharmacist at Sunnybrook Hospital in Toronto, and Dr. Jay Easaw, a medical oncologist from the University of Alberta. Next slide, please. These are the disclosures for each of the panelists and co-chairs for this evening's program. Next slide. And we also wish to disclose commercial support in the form of an unrestricted educational grant from Pfizer Canada, and to acknowledge the following potential conflicts of interest. Slide. We also take mitigating potential bias very seriously here at Thrombosis Canada. So at the end, when you will provide an evaluation for this program, please make it an important part of that evaluation to determine whether there was any perceived bias in any of the discussions that took place. Next slide. This program is also accredited by the Royal College of Physicians and Surgeons of Canada for main pro credits, as you can see, and the accreditation took place through McGill University. So we hope you can take advantage of this accreditation process. The learning objectives, as you will see, are very generic. So we want to have a discussion and engagement with the audience on a number of topics that many of you have provided us in advance of this presentation. So a lot of these topics will be challenges that there may not be a specific answer, but we hope to give you perspectives from the multidisciplinary panel. And we hope that this discussion will help you in managing your patients with thrombosis. And whenever feasible, of course, we will try to integrate evidence and guidelines into the discussion, but we really want to focus more on questions that you may have and you've provided. And on that note, I want to encourage you actually to submit your questions through the chat line during the presentation. If it's something that's very pertinent to a topic we're discussing at the time, we'll digress, or we'll try to leave this at the end of our discussion. So there's plenty of opportunity for you to provide your insights, present us with a challenging case for us to discuss. Again, we are in a virtual round table, so let's just pretend we're kind of in one room together having discussions that are case-based. So with that, let's get started. So the first area that we're going to talk a little bit about deals with COVID. And of course, we've had seminars here at Thrombosis Canada on COVID. And this is, of course, a very important area during this Omicron wave. So here we have some questions dealing with patients who may have COVID pneumonitis, high D-dimer, and high bleeding risk. How do we manage them? and then some corollary questions related to Omicron, the variant in thrombosis, and some also questions related to COVID and long-term management of patients who develop thrombosis. So a lot of questions here dealing with COVID, and of course, the long-term sequelae. And and myself, I'm one of the people that's been involved with the management of COVID patients. And I know Dr. Tagalakis is another clinician internist like myself. So, Vicky, maybe I can just start with you. Any sort of general thoughts about COVID, thrombosis, and anticoagulant management?
Certainly, I think thrombosis and anticoagulants play a significant role in COVID disease, and we really quite quickly were very much informed of this early on in the pandemic, to the point that we've had a significant amount of clinical trials that have been conducted in this area, focusing on actually preventing and or treating actual COVID pneumonitis with anticoagulants, given that early on, both data from autopsies as well as observational studies indicated a high risk of thrombotic complications in these patients. Since then, it's become clear that probably the thrombotic risk is associated with patients who do require hospitalization, and more so patients who require oxygen supplementation. And the studies seem to point toward particularly those with high D dimers, for example, would benefit from anticoagulant. Now, all patients should receive thromboprophylaxis at a minimum when admitted to hospital with any sort of lung infection. And so it's important that our viewers understand that clear adherence to hospital-based thromboprophylaxis regimens that are in place should be undertaken in these patients. But beyond that, we do have data now to suggest that therapeutic anticoagulation actually may, in fact, improve outcomes, COVID-related outcomes in patients who are moderately ill and hospitalized on our medical wards. And so many of our institutions, including ours, have pivoted and revamped somewhat our thromboprophylaxis regimens for those patients that are moderately ill with COVID-19 disease and are admitted to our wards. And so we do, there's a lot of sort of discussion around these cases because we do have to look at risks of bleeding, and the data on risk of bleeding in patients with COVID-19 disease has not been as prolific as the data regarding thrombosis complications in these patients. And so we still have some sort of concerns when we're escalating to therapeutic dose in these moderately ill patients. And so we do an individualized case-by-case assessment to ensure that we're not exposing these patients to harm by giving them therapeutic anticoagulation. And so in my institution, we do subscribe to giving therapeutic anticoagulation to moderately ill patients who are admitted to hospital with COVID-19 disease and requiring oxygen supplementation.
And Alison, maybe I could ask you at Sunnybrook in Toronto, is that the practice that you follow? And again, this is a patient who has COVID pneumonitis, high D dimer. Let's say their bleeding risk is standard. What anticoagulant regimen do you use over at Sunnybrook?
Yeah, so actually at Sunnybrook, we do intermediate dosing for people admitted to the ward. So we use enoxaparin 40 milligrams twice a day, in the morning and at night. We've had a few discussions about whether or not we would want to use therapeutic dosing or not. And it was generally felt that there was no great data saying that therapeutic dose was better than intermediate dose. So we just decided to keep it at that intermediate dose. We use standard dosing in our ICU patients. One question I get a lot about COVID prophylaxis is if somebody is admitted and found to be incidentally COVID positive, they might have a high D-dimer for other reasons, would we give them the escalated dosing? And I do not do that. So it would only be somebody admitted for symptomatic COVID to the ward that we would do elevated intermediate BT prophylaxis.
Right. So just for people with COVID pneumonitis, not with so-called incidental COVID. And actually, it's interesting you say that about an intermediate dose anticoagulation, because if you kind of look at it globally, I mean, talking with some colleagues around the world, there doesn't seem to be a clear consensus. And we do at our hospital what I think Vicky mentioned about therapeutic anticoagulation in non-ICU COVID patients, but there's a lot of variability, and even the guidelines are a little bit all over the place. So I think the message kind of is very individual risk assessment.
Yeah.
But I think the other question that is being asked by the audience member here is, let's say you got a patient who's got COVID pneumonia, and then, you know, they desat a bit, so you do a CTPA and you find a pulmonary embolism. How would you treat that patient in terms of their anticoagulation? And let's say they were already on, I don't know, prophylactic or intermediate anticoagulation. How would you treat them? How long would you treat them for? Maybe Vicky, I can go back to you perhaps on this question.
Yeah, sure. We would definitely treat this patient who has a positive CTP scan for thrombosis with full dose anticoagulation. So if they were on, prophylactic or intermediate, then definitely, and that could happen if this was, for example, a patient in the critically ill unit in our ICU. We do not give therapeutic anticoagulation in our ICUs. So for example, if this patient developed a PE, after being discharged from the ICU to the medical ward, seems to be getting better, and then and that patient would not have been on therapeutic dose anticoagulation, he's on prophylactic dose, and the next day you notice that he's desatting a little bit, and you do a CTP and you find a P, then we would automatically start him on therapeutic dose low molecular weight heparin, barring an assessment, with an assessment of, making sure that there are no issues with platelets or whatnot. We generally will use low molecular weight heparin until discharge. It's just easier, we find, to manage in case the patient requires an intervention the next day. It's much easier to manage low molecular weight heparin than a direct oral anticoagulant. But certainly, once the patient was ready for discharge, we would switch him to a direct oral anticoagulant. And generally, we would consider this, when managing, looking at duration of treatment for a thrombosis. We subscribe to looking at risks of recurrence following a minimum of 3 months of anticoagulation. So meaning everyone gets 3 months, and then at 3 months, we look to see what we think the risk of recurrence would be for that individual should we stop anticoagulation, versus the risk of continuing anticoagulation and what the risk of bleeding. And we know when that blood clot was, associated with a strong sort of risk factor, and by strong, we look at known risk factors for thrombosis, so medical hospitalization, infections, pulmonary infections in medical patients are a moderate to strong risk factor for thrombosis. Then we feel pretty confident that COVID would fall into that realm, and we would stop anticoagulation after 3 months of therapy, because we would consider that the risk of recurrence often for anticoagulation would be quite low, and similar probably to the risk of bleeding should that patient continue. So that's how we would think about this, unless there were other factors that would push me to extend, his anticoagulation beyond that minimum of 3 months. And what could those factors be? I would take a good history. Did the patient have other episodes of thrombosis in the past? Is the patient, other potential sort of synergistic risk factors? Obesity could be considered as well. But in general, I would say it would be around 3 months.
Yeah, and I would agree that to me, this is provoked thrombosis related to COVID and hospitalization. Another question actually that I get asked a lot is, what about that patient who was in the hospital, was on therapeutic or even intermediate heparin, and now they're getting better, they're going home, maybe they're going to a convalescent situation, and maybe they have ongoing symptoms, perhaps related to post-viral or long COVID. Alison, are there folks that leave hospital at Sunnybrook with COVID that receive prophylaxis with a heparin or another kind of anticoagulant?
I'm going to say generally no. I get asked a lot about people who have more or less been cleared of their COVID, but they're now, I guess, have complications from having had COVID, and maybe are in like an ALC kind of setting. My general recommendation to them is if they would give VT prophylaxis to them, to give them until that indication is still there. But are you asking more about like people who go home and are still suffering from COVID?
Yeah. Is there a role for post-hospitalization anticoagulation as primary prophylaxis following COVID pneumonia?
Yeah, so I think we are not standardly doing that. I know there was an RCT that just came out, the Michelle study, that showed a benefit in a highly selected high-risk group of COVID patients. They had a reduction in the primary outcome. As far as I know, we're not screening people for that and sending them home on anticoagulation.
Yeah, and that's sort of the approach that we're doing in Hamilton. The Michelle trial for the audience was a trial of a Douak versus no treatment post hospitalization. It actually showed a benefit, but it was a very small trial in a very highly selected population. Are you sending anybody home on anticoagulants, Vicky, after COVID in Montreal?
No, we're not, as a general rule, and there will be more studies coming on this issue, and that will be very useful to us. I just have to say that this business of extended thromboprophylaxis in medical patients is an ongoing discussion that's been going on for years and years, and I think COVID adds to that interesting discussion. I think what I've learned from these other studies that have looked at medical patients in general and extending thromboprophylaxis after discharge up to 30 days is what we're probably going to see. Maybe there are in the studies that will come in COVID, there may be high risk type of individuals that probably would benefit. But at this point in time, we don't have that data.
Yeah, so the default is no, and only maybe for a small minority that's particularly at high risk.
Yeah,
okay.
Exactly.
We are getting some questions from the panel, and then we're going to come back, but I want to move us ahead to a little bit of a different topic and go to the next slide. So I want to just talk a little bit about cancer-associated thrombosis and focus on a recent Canadian publication that actually Dr. Tagalakis was a co-author, and looked at providing some guidance to clinicians. And I'm going to maybe turn it over to Dr. Easaw, our medical oncologist, to maybe guide us through the next series of slides. Jay, your take on these guidelines, and there's an algorithm that follows for the general management. How do you kind of incorporate this in your practice as a medical oncologist?
Yeah, we follow this. This is a very practical user-friendly algorithm. And for those of you that aren't familiar with this and treat cancer patients, this is an excellent, thorough, simple approach to deciding whether to use a Douak or low molecular weight heparin. And I'll just walk you through it. So you have a patient with a cancer and they develop a blood clot, PE, a DVT. There's a series of questions that need to be asked. The first is, what is their risk of bleeding? Do they have a high risk of bleeding? And if they do, the preference is to lean towards a low molecular weight heparin. If they have a relatively sort of upfront low risk of bleeding, then asking the question, what kind of cancer do they have? If it's an unresected intraluminal GI or GU cancer, these are cancers that are high, that multiple studies have shown are at high risk to bleed. So in those situations, a low molecular weight heparin is preferred. If it isn't GI or GU cancer, then the next question is drug-drug interactions. There are new drugs coming out all the time, and they always need to be double-checked. But even the drugs we have, there is the potential for drug-drug interactions, or what we refer to as DDIs. If there is an interaction with a Douak, then we lean towards the low molecular weight heparin again. So you see that sort of these three key questions have to be asked. If the answer is no to all of them, then a Douak is reasonable and can be used. I would say that the most important thing, though, is constant reassessment. And this is particularly true for something like metastatic cancer. So I treat metastatic colon cancer, for example. Patients will progress, we'll switch them to a new regimen. They'll progress, we'll switch them to a new regimen. And if the team isn't regularly going back and reassessing the new regimen that they're on, their current status for bleeding, like I said, the regimens that they're on, this could get missed, and then they could now be put on a regimen that could interact with the Douak. So I can't emphasize that enough. And then we go down the algorithm to the cancer status. And the way I have used this is really very simple. If it's metastatic disease, we treat with chemotherapy for life. We treat for as long as they'll tolerate the chemotherapy and as long as it's working. But in a curative setting, let's say someone with a stage 2 or stage 3 colon cancer, we'll give them chemotherapy for 6 months, and then we're done. So in that kind of environment, a Douak makes a lot of sense because it's a short treatment. It's only one treatment. It's not going to change. So I think that overall, this is an excellent algorithm, very, very user-friendly, and asks the key questions that we would want to know when we're managing someone with cancer and a clot.
Well, thank you for that elegant overview, Jay. I mean, I think what I'm hearing is that there's some general principles, but it's very, very patient-centric. And then if we go to the next slide, this whole area is kind of rife with what-if scenarios. So here are just a small cluster of what-if scenarios. And Jay, once again, if we can lean on you and ask you about how you might, deal with, somebody with who has post-op GI cancer, or in your case has advanced, metastatic GI cancer, or develops thrombocytopenia from chemo, or maybe not directly in your specialty, but has involvement in the brain. Can you give us what your take is, how you would manage these patients in Edmonton?
Right. Resected GI cancer. So if the tumor is still there, let's say in a metastatic setting, these tumors are at risk to bleed. And so in that setting, probably not a good idea to, or at least consider a low molecular weight heparin. But you might think like, well, you've got an upper GI cancer, so let's say a stomach cancer, and it's been resected. Well, if the risk of bleeding is now gone because that intraluminal cancer is gone, well, why don't we go with the Douak? Actually, the Douak may not be a great idea in this situation because the Douaks are primarily absorbed in the upper GI tract. And so if you have a significant resection in the upper GI tract, it actually, using a DOAC actually could be a bad idea because the drug itself may not be properly absorbed. The second comment about severe thrombocytopenia is really interesting. Someone has an acute blood clot, has severe thrombocytopenia, let's say chemotherapy induced, for example. The example here also uses an acute leukemia, but chemotherapy is very common to cause severe thrombocytopenia. What do? This is a very difficult situation to deal with, especially if the platelet count is going very low. What our practice here in Edmonton is to actually transfuse patients with platelets, especially if we feel that the platelets will recover on their own, especially in chemo. If we give them a break, we give them some time, let the chemotherapy-induced thrombocytopenia recover, we will actually transfuse them with platelets so that we can carry on with the anticoagulation, particularly in an acute VTE setting where the risk of a clot is quite high. That's our approach. I don't know if amongst the panel if you have a different approach for that particular question.
Yeah, maybe I can ask Alison or to these issues that Jay brought. I mean, is there something that you might do differently at Sunnybrook, or any additional thoughts that you may want to supplement Jay's comments with?
Yeah. So we generally do tend to favor using DOACs up front unless somebody has an in situ GI or GU tumor. If the primary has been resected, we're usually okay using a DOAC as long as there's no other mets or known lesions that are invading into the GI or GU system. In terms of thrombocytopenia, we generally do not transfuse. We try to avoid that. There are a few times we have done it. But we will usually just dose reduce and try to get them back on the full dose anticoagulation as soon as the platelets allow. We will do, if somebody has a pulmonary embolism, we will do Dopplers of their leg to try to risk stratify them so that we know that if they go to a point where we can't anticoagulate them at all due to their platelet count, if we want to do anything further, like maybe we will push harder for platelet transfusion or potentially a filter, but we hardly ever do that. But yeah, I would say we very rarely transfuse for low platelets, and we just anticoagulate them to what their platelet count would make us feel comfortable to anticoagulate them. That's pretty much it. In terms of the last question.
Yeah, I was just going to say, in terms of the last question, that's a challenging one. Somebody that has acute pulmonary embolism in the setting of a malignant brain tumor. I
actually treat glioblastoma, so this is a question for us that we deal with. Our preferred option is actually low molecular weight heparin.
We use DOACs a lot.
We have found the surgeons tell us when they go in and operate on a GBM that the blood vessels are very friable. They're not mature blood vessels that are invading into the tumor, and a lot of these tumors, especially if they're going for a large resection, can bleed. So our preference has been to lean away from DOACs just because of this potential increased risk of bleeding. But I don't think there's really very good data here to guide us.
Vicky, can you maybe weigh in on these slightly different views?
For the last question? Yeah. I would probably, Jay's right, there's not a lot of data to inform. There are small series, either, retrospective observational data where, people look back and see what happened to, cases of glioblastoma that were put on low molecular weight heparin and what happened to those that were put on a DOAC. And obviously they're fraught with, indication bias, meaning you may have preferred to put somebody you thought was at a lower risk on a DOAC or vice versa. And it seems to show that, there may not be such a difference between the two molecules. But obviously these are not randomized clinical trials. So having said that, though, we kind of do a lot of consulting with our oncologist and our surgeon, and we generally, I say, we'll start with low molecular weight heparin. As we get comfortable and we see how the patient's doing, we generally will switch over to a Douak after, seeing the patient, having a discussion. But we're getting more and more comfortable, I think, using the Douaks with these patients. But I do, it's not escaping me whatsoever that what Jay talks about is our neurosurgeons also talk about, a more friable tumor than what would be with a regular metastases from a solid tumor like breast or lung, for example.
Okay. Well, thank you. Before we go on to another topic, one of the very common what-if scenarios in cancer patients is the finding of a thrombus in an unusual location, like the splanchnic veins, or as in the lungs, but it's just a segmental or subsegmental clot, and these are incidental findings. Jay, can I just come back to you? How do you see a lot of these?
Yeah.
How do you handle these kind of situations?
Yeah, in the GI setting, for example, we're doing, scans of the chest, abdomen, pelvis, looking for recurrence or progression, and not uncommonly we'll be called about a clot in the splanchnic circulation, for example. In that situation, our general practice is to anticoagulate. That's what we do. Where it's more difficult is in the subsegmental, clots, because what we've observed is it seems like it's very much reader dependent. If you were to take that same scan and show it to another radiologist on a different day who wasn't the original person reading it, sometimes we'll get a different opinion of whether that's a clot or not. So I think that in general, if we get confidence that there's a blood clot from the radiologist, though, our tendency has been to treat.
And Alison at Sunnybrook, I mean, you're at some major cancer center as well. Would you agree with what Jay said?
Yeah, I would say in general, if they've clotted, they've been proven themselves to be clotty, and we will treat them. It can depend a bit on the scenario. So somebody had like a splenectomy and then were found to post-operatively have a clot in their splenic vein. We wouldn't be surprised by that. And then we might treat them for a shorter duration at a lower intensity. We see a lot of incidental pulmonary embolisms. I would say we tend to treat those usually. If somebody has an isolated subsegmental pulmonary embolism, it can be a bit more individualized.
Yeah. And Vicky, is there a kind of preference, let's say in your practice, for a Douak or a low molecular weight heparin in these sort of incidental clots that are identified?
No, we would treat them as we would according to, if it's a cancer patient, according to that algorithm that Jay went through, and looking at other factors that would push me toward low molecular weight heparin or a Douak in a cancer patient. So there wouldn't be a difference based on whether this was a incidental or a subsegmental that I choose to treat.
Yeah. So I think the message I'm hearing is that the default is to treat these patients. They're prothrombotic because of their cancer, and even with small clots in the lungs that may be subsegmental, I think there is some evidence to support treatment. And what we don't know is how well Douaks or low molecular heparins work, and of course we can rely on the algorithm. So let's move ahead now and just shift gears a little bit to the next slide. And there's a number of questions here, some of which I think we've already touched on, but they kind of deal with Douaks in patients who have chronic kidney disease or, let's say, chronic liver disease. And maybe, Alison, I can come back to you. As a pharmacist, you're kind of providing a check and balance to the physicians about when you should, or more often when you should not be using DOACs. What's your kind of approach to somebody who has chronic kidney disease or liver disease in terms of do's or don'ts with DOACs?
Yeah. So for VTE, all the DOACs are approved to be used down to a creatinine clearance of 15 mils per minute. And so if somebody has chronic kidney disease and their function is relatively stable and they're above that limit, I'm very comfortable using a DOAC. In somebody on dialysis, I'm also very comfortable using a DOAC. We have been using apixaban in patients on dialysis for a very long time now, and it's gone well for us. That is not based on a lot of evidence. The best evidence is probably the Subsegmental study that came out in circulation a number of years ago, which was a large observational study in AFib patients on dialysis that showed apixaban had less bleeding than warfarin. So we generally tend to favor apixaban in patients on dialysis, largely based on that study. There's been a few other studies. The renal AF study closed. It's, as far as I know, not published in a peer-reviewed journal yet, but its results are available online and were reassuring that apixaban did not increase the risk of bleeding compared to warfarin. And there was also the Valkyrie study, which is an interesting study, but looked at using rivaroxaban in patients on dialysis. So I am very comfortable using DOACs in patients in dialysis. I generally favor apixaban though. When it comes,
okay.
Sorry.
And what about in liver disease, Alison?
Liver disease, I feel like there's a lot less data. We'll see case series from what I've read. Most of the RCTs excluded people who were high risk. I would say I'm generally comfortable using a DOAC in somebody who's a Child-Pugh class A. When somebody hits Child-Pugh class B, I kind of start looking at other things that then their renal function might start to be going downhill, which might make me a bit nervous. Or other stuff is going on with them, like they have varices and things like that, that would make me nervous. So I try to look at the whole picture. I would avoid using DOACs in somebody who's Child-Pugh class C. Sure.
Okay, well, I got to say that in our place, we're a little bit more reticent to use apixaban or other DOACs in people who are hemodialysis dependent. I think the literature is evolving in this area, so I think it's something that we want to tread with caution. We just got a question from an audience member relating to portal vein thrombosis, and maybe Vicky, I can direct it toward you, who has, and Jay, please feel free to weigh in, a history of resected colon cancer, but no evidence of metastatic disease. So maybe this was an incidental finding on a screening CT, and there's no evidence of active disease. Vicky, and then maybe Jay, how would you handle this situation? And would you treat it first of all, and if so, which agent would you consider using, a low molecular heparin or a DOAC?
Yeah, I think it's an excellent question, and there's many factors that come into play. First of all, just as a general statement, so portal vein thrombosis and all other types of splanchnic vein thromboses are gaining we are gaining experience vis-a-vis using DOACs in these individuals, as opposed to the alternative often being Coumadin. So I'm talking in general, because low molecular weight heparin could also be an alternative if dealing with a cancer patient, for example. And so there is increasing studies, and there are some guideline recommendations that would suggest, not fully recommend, but provide suggestion for DOAC equally used with low molecular weight heparins or Coumadin when there is a decision made to proceed with anticoagulating a portal vein thrombosis. And in a patient, for example, with cancer and portal vein thrombosis, I would feel compelled to treat that, given that the patient is prothrombotic from their underlying malignancy. And so a portal vein thrombosis is one of these manifestations or phenotype of that tendency. And so I would subscribe to the same sort of algorithm that we presented earlier, barring any underlying cirrhosis, though, because as Alison eloquently stated, we don't have much experience in patients with liver disease past Child-Pugh A vis-a-vis using DOACs. And so the goal here is in a cancer patient is probably to prevent that other blood clot coming, you know, it could be a PE or it could be a DVT because of that prothrombotic potential. Other times it could be a portal vein clot incidentally found, or somebody comes in with pain or whatnot, and they don't have cancer and they don't have cirrhosis. And in those cases, you have to think about treating it if you don't find a factor. So if they didn't just have their gallbladder taken out or whatnot, then I would feel comfortable not treating it in that surgical case because the mitigating risk factor has been removed, so to speak. The patient is far removed from their surgery and they don't have any other risk factors. But in patients where we don't really know, then obviously I would treat just because I'm going to be quite compelled to think about factors like an occult malignancy, for example, being an indicator here.
Yeah. And Jay, do you agree with Vicky?
Yeah.
Any other thoughts from your experience?
I think Vicky hit all the highlights. For me, just this patient has a history of cancer, with no evidence of new disease. Could they have occult disease? Possibly. But personally, I would follow the algorithm here. I think that would be, and I would, with the intent of treating. So I think a DOAC in this situation, if it meets all those criteria, very reasonable here.
Yeah, and of course, as was indicated, we need, the data are emerging in this area. I want to go back to the first bullet point about kidney and liver transplant surgery, but not focus on the surgery per se, but deal with the fact that these patients are typically receiving multiple immunosuppressive agents, and there's the potential for drug-drug interactions. And maybe Alison, I can just go back to you. That's what's your just general take on drug-drug interactions with DOACs? And we don't have to focus on immunosuppressive agents, but are there any kind of top line, do's and don'ts that we need to be aware of in terms of DOAC DDIs?
Yeah. So drug-drug interactions with DOACs is like $1 million question. My stance is it's a hard no on things that I know are strong inhibitors or inducers of CYP3A4 or PGP. And if you're looking for a good list, I tend to like to check the Caravaggio and the Hokusai protocols. They have good lists on there. But to me, red flags for inducers that would cause DOAC levels to become lower are things like phenytoin, carbamazepine, rifampin, phenobarb, but I've never seen somebody on that. And then inhibitors would be most of your azoles. I'm okay with fluconazole. And then other big things that are inhibitors, strong inhibitors, aren't super obvious. Most things are kind of listed as strong to moderate. So you might see things like cyclosporin or tacrolimus. And if somebody's on multiple moderate inhibitors, what do you do? Nobody really knows. I think it's patient comfort level with the lack of data and the practitioner. But as long as somebody's not on something that I generally recognize as a strong inhibitor inducer, then I'm okay with them being on DOAC.
Okay, so there are some clear do's and don'ts, and actually Thrombosis Canada also has a nice little summary that we're really fast forwarding to that we will highlight here. but provides a nice summary of potential drug-drug interactions. Oh, we just skipped it. There we go. So we're not going to go through each of these. We'd be here till midnight at least, but it just is there as a resource. And I just want to also highlight, getting back to COVID, that on that list is the drug ritonavir, which, as you all know, is part of Paxlovid, recently approved outpatient treatment for mildly symptomatic COVID-19 patients. So I got to ask maybe Alison or Vicky, so you've got one of your patients, they're on a Douak, and now they get COVID-19, and what are you going to tell them? Should you take the Paxlovid or maybe just hold the Douak, because it's, as Alison said, it's a CYP3/4 inhibitor, so it may lead to higher anticoagulant effects and may increase the risk for bleeding. I don't think there's a right answer here, but what would you do in that situation, Vicky?
Yeah, no, it's a quite unique situation. I have to admit we haven't been faced with it as of yet, but I'm sure just because it is a fairly new available medication, and we're going through our own protocols to know to be able to prescribe it. It's a short light, and I don't know, correct me if I'm wrong, I'm not quite sure how many days it's for. Is it 14 days or it's
I think it's 5 days, but I don't think that, I'm not trying to put you on the spot, Vicky, because there's no right answer, but I think I'm just trying to highlight how we often overlook potential drug-drug interactions with DOACs, and this is something that's kind of come to the fore because of COVID.
Yeah, I'm not so sure how, just because that's what I was getting at. It's a short-lived treatment. And so I'm not quite sure I would be so concerned with any significant interaction. It would really be a case by case, but in my mind already, I'm thinking that short course, if it is 5 days, I can't remember, I'll take your word for it, that it would not sort of be as significant of a effect modifier here on the anticoagulant.
Okay. Well, Alison, unless you really want to weigh in, I just wanted to make people to be aware of this, and whether they just continue the DOAC or just hold it for a few days because of the potential interaction. I think awareness is the key thing in this situation. But if you have any thoughts, please share them with us.
I would avoid it. I would try to reassess why they're on a DOAC. If it's like secondary prevention and they're just on the ritonavir for a few days, I would probably just hold the Douak while they're on the ritonavir. I'm not very familiar with ritonavir for COVID. If they're in the hospital, then I just give them low-mech weight heparin while they're on the ritonavir, and then once they're off of it.
I don't think it would be for hospitalized patients, but
I think the message here is that you have to look at it on a case-by-case basis. Maybe there's some patients that you might feel comfortable holding their DOAC, maybe if they've been on it for many years for secondary VTE prevention. In other cases where you won't be because they have a more recent thrombotic. So just be aware of the drug-drug interactions, and have a look at our Thrombosis Canada sort of table on that, and sort of look at it on an individualized basis. And then just really quickly about this issue of ASA for VT prophylaxis. So we're doing it more and more after orthopedic surgery. And do you think it'll work in patients with dialysis? It's hard to say whether, this is a high-risk population for many things, both bleeding and thrombosis. If the aspirin was studied in patients after orthopedic surgery who were generally otherwise healthy and then could be ambulatory. So I think for dialysis patients, I probably would go to a more conventional type of prophylaxis. And if you're not comfortable using a short course of low-mech weight heparin, maybe unfractionated heparin, but although we try to avoid that completely, I'm not sure I'd be just comfortable completely on aspirin, but I don't know, maybe I'm an outlier. Vicky, what do you think?
Well, I think I mean, in trauma, we don't really have, the data for orthopedic traumatic type of, like hip fractures or that type of thing to substantiate the use of aspirin. We do have the data coming for elective hip and knee arthroplasty, for example. So I would agree with you. I would probably not be comfortable using aspirin.
Okay. All right. Let's move on just in the interest of time. It's time flies when you're having fun, and it seems like we are here. So we want to just shift gears a little bit more and talk about patients who are obese and require anticoagulant therapy, in this case for VTE. Alison, maybe back to you. What's your kind of general approach to use of anticoagulants in the obese patient with an acute indication for anticoagulant therapy?
Mm-hmm. So I think one of the most common questions is like, what is your weight cutoff for using a Douak in an obese patient? I would say, generally speaking, anybody under 150 kilos, I'm okay with using a Douak for VTE. If somebody's between 150 to 200 kilos, it would depend on the VTE event, but the data is very reassuring that Douaks are safe to use in people who are obese, and that we don't have to really worry about it. And recently the ISTH just came out with new guidelines and does not have a weight cutoff for using Douaks in people with VTE. So I get more worried about people who are underweight.
Yeah, I saw that, Alison, and I got to say it kind of raised a bit of a Spockian eye, and that's a Star Trek reference, by the way, but that we don't have an upper limit, that we should refrain from using a Douak. Vicky, what's your thought about this, Douaks in the obese population?
Yeah, no, I think it's I'm along the same lines as Alison, although I would say my cutoff is probably, so by product monograph, we're looking at a 120 kilo cutoff for the Douaks, most of the Douaks. So I get comfortable, everybody has this set point, but I start getting nervous above 135. So although we do have very sound observational data and data that has used large administrative databases as well, that have addressed in AFib patients and in VTE patients, looking at stroke, for example, or systemic embolization in patients with AFib, and in VTE looking at recurrences. And it seems to be that there is no sort of difference in those who are overweight or obese versus those that are not obese. And now, granted, in these studies, obesity is defined differently, but I'm reassured by that in that data, but I still have a bit of a cutoff of 135. And one of the things I tend to do, for example, is I may start with a low molecular weight heparin for a couple of weeks. And then once I get out of that acute phase, then I'll switch them over to a Douak. The nuance here is that it depends what province you're in, obviously, but coverage, one of the things that we deal with in Quebec is that, in the province of Quebec, is that when a patient has an unprovoked, for example, thrombotic episode, whether it's a DVT or a PE, we have coverage for example, apixaban past 6 months for secondary prevention using the 2.5 milligram dose. So the province will cover the 2.5 milligram dose. And so let's say you have a morbidly obese individual, has an unprovoked PE, So unprovoked means that I would venture to treat this patient indefinitely, or at least long-term, past 3 months. And so they're morbidly obese. I started with my low molecular weight heparin. We did it for a month. The patient did well. We had a frank discussion about, the data using Douaks. And then we finally agreed to switch to, apixaban. And so then we come up to 6 months. And then the government has providing coverage for it. And at 6 months, because I'm not comfortable switching to the 2.5, given that the patient's weight, we then have a discussion about the price going up on the medication. Whereas I do see a lot of other folks, I fear a lot of other, healthcare providers may choose to downgrade down to the 2.5 milligram because of coverage. And now that I'm a bit weary of. So it's a unique type of problem we have.
And I just want to go back to Jay, just from your experience as an oncologist, where, you may be dealing with an obese person, or you may be dealing with somebody with weight fluctuation. You talked about how, this is a very dynamic situation. And any experience from that perspective, Jay, that you can share with us?
I have to be honest. I haven't treated anybody that's been sort of over 120 kilograms. I've never treated anyone over 150 kilograms. Up to 150, actually, I'm comfortable as well using a Douak. So I'm maybe more, if they fit all the criteria, I'm okay to treat them. Where we see in terms of weight fluctuations is typically weight loss, and not gain. And so, the way it works here at the Cross Cancer Institute in Edmonton is that if there is not a 10% change in weight, we keep the chemotherapy the same. We won't change anything else. But if we had someone on a low molecular weight heparin and their weight dropped precipitously, we will redose it. The Douaks typically have more of a more constant dosing. So that's a situation where I haven't had to change the dose of a Douak. If someone got very, very low in their weight, typically someone's dropped their weight precipitously and they're incredibly low weight, they're probably not well enough for chemotherapy. So at that point, we're thinking about other things, like more palliative kind of approaches in that situation. So I can tell you honestly, I haven't had to deal with someone with the low weight, because usually we have to stop chemo by that point.
Yeah, but I think what you're hearing and emphasizing your previous point about the need for ongoing monitoring of these patients, because circumstances and goals of care may change. So no, thank you very much, Jay. All right, we're kind of into.
Yeah, I just wanted to add the only other, maybe Jay, is in oncology and obesity is usually the endometrial cancer. You may sometimes see in that patient population. That's where I would see in a cancer patient population overweight, obesity being an issue.
Got it. Yeah, not a cancer I treat, so totally.
Yeah.
Totally easy.
I just want to throw one tidbit in about underweight patients. We use edoxaban a lot in patients who are underweight because it has that dose reduction criteria for weight alone, and so we really like it for that reason. In people who are underweight, we can justify using the lower dose.
What do you mean by that, Alison?
So if somebody is under 60 kilos, you can use the edoxaban 30 milligrams. And so let's say somebody's 42 kilograms, but they just had a VT event and we want to use a Douak in them, but we don't want to give them like a huge full dose. We can give them the edoxaban 30 milligrams, and that's considered a full dose, but it's like a dose reduction. Does that make sense? They're getting the lowest dose, but it's justified as like a full dose for them for their weight. So we have like a weight-based dose for them with the edoxaban. Whereas with the other Douaks, you don't have a weight alone criterion to dose reduce them for VT.
Yeah, that's a great point. And I think it just speaks to how we should the individualized patient care and using and looking at the differences across DOACs. They're not the same, and different regimens and doses have been studied. And once again, Thrombosis Canada can help in those choices that you want to tailor to your patient. All right, we're going to move on. We're in the home stretch now. We're going to move on to the section on some general questions, and I'm going to hand over the chair to Dr. Tagalakis to take us through to the finish line. Vicky, over to you.
Thank you, Jim. So we also received, as Jim pointed out, some general questions. So we thought we'd sort of talk around some of these questions as well. So the first one had to do with having someone who was at a high risk of bleeding, or probably more common is they recently had a bleed. Commonly, we would be encountering a patient who requires anticoagulation and just had a GI bleed, for example, and they get scoped and they find, a bleeding ulcer, and it gets their source control achieved. And the question always then is, when can one resume anticoagulation? Perhaps I can start off with maybe Jim, and then particular to GI bleeds, and then perhaps with Jay, we can think about this being a patient who has had a cerebral mets and they bled, and what would we do thereafter? So if in the case of a GI bleed, what do you normally do, Jim?
The message that I would try to convey to people who ask me this question is that your default option should be to try to resume anticoagulation. And there are data that support this approach, suggesting that you reduce the risk for stroke or thrombosis, you reduce mortality. And of course, there is a price to pay with more bleeding, but it is outweighed by the benefits. Now, having said that, there are maybe specific situations where you cannot resume anticoagulation. So if somebody has, gastric antral dysplasia or watermelon stomach or a non-resectable tumor, then it gets more problematic. But that's the first point. You want to restart as a default, and the timing is always really tricky, and I struggle with this even after many years of practice, because once again, you're weighing so many individual factors, not least of which is the patient, the type of bleed, the risk for rebleeding. What I do in all of these cases, Vicky, is I have a nice talk with the gastroenterologist who's actually seen the lesion and say, when do you think this patient would be safe? When is the healing going to happen if it's an ulcer? And when can I kind of start with anticoagulation? And sometimes what I do is I actually start them on a low dose and ramp them up. Now, there's absolutely no scientific evidence to support that, but it gives me a little bit of a margin for error, if you will. So those are the things that I would do. Resume when I can, avoid in certain circumstances, but always talk to my GI colleagues. Okay.
And Jay, often, there may be a situation where we have patients with, a PE and they have lung cancer or colon cancer, and there's probably less so with colon cancer, but breast cancer or lung cancer with cerebral mets, and there's this fear of bleeding. Is there would you manage a patient like this differently? So let's say they didn't bleed, would you choose low molecular weight heparin over a Douak, and what helps you decide?
Yeah, so my own personal approach, as I mentioned before, and I would throw glioblastoma in here too, is to try and treat that clot. And but this is a conversation with the patient, because they need to understand they could stroke, and not as worried, to be honest. There's certain kind of mets that, like a renal cell or a melanoma, those are higher risk to bleed. Breast cancer mets, not as common. GI mets, not as common. So I think that's just kind of a conversation with the patient to say, listen, you have a melanoma, there's a risk that you could bleed. We would recommend that we go forward, but some patients will not take that will not
Right.
take that risk. And it also depends on the type of chemotherapy that we're going to be giving them too. Some are higher risk of causing more thrombocytopenia, let's say oxaliplatin for GI cancer. They would need to know that the chemo that I'm going to give them is introducing an even further risk on top of what they already have. So that it really is a complicated conversation with the patient.
Okay. Yeah, no, I think the message here is obviously it's case by case, as a lot of these scenarios require a nuanced kind of look at risks of bleeding versus risks of stroke or having a PE recurrence or a thrombotic recurrence. And it's and there's no sort of rule book per se, and we all struggle vis-a-vis reintroducing anticoagulants, both timing and type of anticoagulant. It's interesting, Jim, you talk about reducing the dose, and it's something certainly I will try as well to do. And sometimes I'll use one molecule for the first few days and then switch over to another molecule. Okay, the next question has to do with the management of Coumadin perioperatively in a patient with a mechanical valve. So some of the considerations that go into having a patient who has a mechanical valve and needs to undertake surgery, how do we manage that Coumadin, and what are some of the factors that come into play to determine how we manage Coumadin? Or do we bridge? Do we not bridge? Does it depend on the patient? Does it depend on the valve? Maybe what I could do is first start with Alison. Do you have set protocols perhaps at your institution to help guide that decision making?
We do, largely based on the bridge study, which Dr. Douketis did. But so if somebody is a mechanical mitral valve, we pretty much always bridge them. The mechanical aortic valves, we are tending to lean more not to bridging them, but a lot of them have been bridged in the past and get kind of freaked out by not being bridged now. So it's a bit more individualized for them. But generally speaking, if somebody is not an old mechanical aortic valve, we might not bridge them.
Okay.
And we will do like low white heparin. We do it once a day. We generally do it, tell them to take it in the morning, the last dose the morning before the procedure. I know that Thrombosis Canada generally recommends BID dosing with low white heparin, and to take the last dose the morning before and skip the night before. Okay.
Jim, any thoughts on the process, and what have you seen evolve since the bridge trial, and perhaps focusing on changes you've seen that in implementing a protocol at your institution, for example?
No, thank you, Vicky. I think the bridge trial, and then there's the Periop 2 trial, they collectively have taken off the bloom, if you will, of bridging for patients on warfarin. There are situations, as Alison alluded to, a mechanical mitral valve that we probably will continue to bridge. Although I think after surgery, especially let's say it's a cardiac or a neurosurgical or spinal procedure, I'm not bridging those patients. I might use a low dose heparin while the warfarin is resumed, because the bleeding risk is so high, and even if it's a small bleed in those locations, that can be very devastating. The only other point I'd like to make is that there are more and more situations where you don't have to stop the warfarin. So somebody's getting a pacemaker, an ICD, or dental procedures or other GI procedures, you could generally continue with the anticoagulation. Just make sure the INR is not too high around the time of the procedure.
Yeah, and that's a very important point. There are increasing society-based recommendations, for example, from the GI, the American Society of Gastroenterologists, and the Canadian Society of Gastroenterologists, who do provide guidance on, for example, that very fact about continuing anticoagulation when undertaking certain types of low-risk procedures. I'm going to, we have a third question here. I must admit it's something that I have never crossed or seen before. It's a 49-year-old man with bilateral ulnar artery thrombosis. So here we have an arterial thrombotic event, and it's in both hands. And the MR shows hypothenar-Hammer syndrome, although there's no history of this before. Is there a role for anticoagulation? So it seems to be that I may have to go to my panelists. Maybe Jim, do you have any experience with this?
I do not, and actually, this is just how we're all here to learn, and I'm certainly learned about hypothenar-Hammer syndrome, which I haven't had a chance to look up yet, but I think the point is that you're dealing with a situation where you may have trauma or repetitive injury induced vascular injury that leads to thrombosis. I think the only thing we can say, of course, you can administer an anticoagulant empirically in a lot of these situations, but typically if the pathophysiology is more related to a mechanical issue, I mean, the other example would be, hemodialysis lines, then surgical interventions would be an option that you look at more. So apart from that, I mean, I don't think there's anything wrong with, treating something like this with an antiplatelet drug, but it sounds like it's a surgical issue more than a medical issue, in my view.
Yeah, and as you were, mentioning that, I just want to also highlight to the audience that, it does sound like it is a mechanical and a surgical problem, but whenever you do have an arterial thrombosis, just think about what could be the underlying issue. And often atypical systemic embolization needs just kind of a reboot and thinking about, cardiac emboli or, other sources of embolization. So that's why I think that was the first thing that came to my mind when I was reading that scenario. And so sometimes things like antiphospholipid syndrome and so on should be thought of when being presented with this type of situation. Okay, I just want to, before we move on, we have about 15 minutes left. We'll move on to the next slide, and this is the slide here. I think this is our last slide, and if we have a few minutes at the end, we can perhaps address one or two of the questions in the chat box. So here we have the general question is how to manage reinstating anticoagulation post-bleeding event. I think we touched upon that already, or who gets bridging and who is safe to not bridge. So I think we sort of addressed that with the earlier question. In brief, it's not very easy to know how to reinstate anticoagulation case by case, as we talked about. And speaking to the individuals involved, like a gastroenterologist or your neurosurgeon, is quite important to determine the timing, for example. The next question asks, the indication for, and I assume APS is antiphospholipid syndrome, dosage for first VTE anticoagulation. So perhaps this is, I'm going to assume that the audience member is asking about how to manage a patient with VTE and antiphospholipid syndrome. Could be one of the ways to interpret this question. And it's an important question if indeed that's how we're interpreting it, because there is some nuances here. I'm not sure if, Alison, you have some experience in your institution as to how antiphospholipid syndrome patients who often get a thrombotic event may get a screening for antiphospholipid syndrome only because perhaps this was a clot in a very young individual, or this was an atypical clot such as a cerebral sinus vein thrombosis. Something was extremely provoking about very sort of sentinel about that event that led to this screening, and now we find these antibodies. Any difference in how you manage that patient?
No. So if somebody, if we're suspecting antiphospholipid syndrome, we will generally start them on warfarin until we have their antibody profile. And if they're triple positive or they've had an arterial event, we will keep them on warfarin. The people that would tip us off to suspect antiphospholipid syndrome are people who have clots in unexplained weird areas, maybe have slightly low platelets, maybe a slightly elevated PTT, or they broke through anticoagulation. Those are kind of the people we might think it's APS, and then would want to check their antibody presence and levels. Or if they've had an arterial event, like a young person having a stroke is pretty much the one I see the most.
Right.
Yeah.
Jim, is that what you generally do as well?
I would, as Alison said, if you have patients who have confirmed APS or APLA, then you want to avoid the direct oral anticoagulants and use a heparin or a vitamin K antagonist. The only thing I would add is the confirmation part, because I see so many patients who are labeled as having APS or APLA and they don't fit the criteria. So as Alison said, if you're going to be testing, I would recommend making sure you retest at a time that is remote from their thrombotic event, and preferably off anticoagulant therapy temporarily, because it is a diagnosis that is sort of fraught with many false positive situations. And as Alison said, it does have implications on management.
Yep. Great. Thank you. The next question or comment is low-dose aspirin recommended to prevent recurrence of thrombosis? So by this, I assume the audience members talking about secondary prevention. So we've had an individual who had a blood clot and got treated for the initial period, whether it was usually 3 to 6 months, and there is now a need to continue some sort of preventative therapy because it is deemed that this individual is at a higher risk of thrombosis recurrence. And would aspirin or low-dose aspirin be medication that one could use to do this? So it's interesting. I don't know, maybe I'll begin with Jim. What do you think?
I'd like to answer this, but there was also another question from a audience member about when to re-image and if we should be re-imaging. So if we take a patient that has had a thrombotic event, whether it's pulmonary embolism as the manifestation or deep vein thrombosis, in general, you don't need to repeat the imaging for the PE, whether it's a CTPA, autoradiation, or even a VQ. And we only do it for the lower extremity or deep vein thrombosis when we're stopping anticoagulation, because we want to have a frame of reference in that in case that patient comes back with suspected recurrence. So it really isn't there to determine the duration of anticoagulant therapy. That's based on other factors and symptoms being foremost. But as regard this question about where do we use aspirin, I personally don't use it anymore. Because my decision is I continue anticoagulation or I don't continue, especially in an elderly population where we know aspirin comes with harms. So I don't have a role with it, even if patients say, well, can I just take an aspirin, doc? And I say, well, yeah, you can, but I don't recommend it as for secondary prevention. If I wanted secondary prevention, I would put you on a low dose Douak as an example.
Yeah. Alison, you would agree with that?
Yeah, I think there is still a pretty strong notion that aspirin is a not benign, but like not a harmful medication. And I just feel like we know that apixaban is effective, or the DOACs are effective at reducing recurrent VTE. And when we compare DOACs to aspirin for VT prophylaxis, or even in elderly patients on AFib, like in the AVRO study, we know that aspirin has a similar bleeding risk. So I think if you're using aspirin to like try to lower the bleeding risk, it to me is not helpful, and we don't know that it's as beneficial as anticoagulants for long-term VT recurrent prevention.
You're very right, Alison. And actually, we do know that it is not as effective as long-term anticoagulant use. And there was these past studies, Aspire and Warfasa, that looked at this question. And so you're very right in that comment. Okay, and I think we'll comment on the last question that's here. So the last question that we're going to discuss, and maybe there's something more in the chat box, I'll check quickly, is, we just zoomed by, sorry, can we, sex difference in recurrence rate of VT and how to use the clinically retreatment duration, for example. So this is a great question. It's addressing the role of female or male sex in determining one's rate of risk of recurrence of thrombosis, and whether we use this to be able to determine duration of anticoagulation. I guess maybe I'll ask Jim here. What do you do? Do you treat men versus women differently in your clinic vis-a-vis who've had a blood clot, vis-a-vis the duration of therapy, or even the type of therapy?
Yeah, no, I think the short answer is no, Vicky. I think the only thing that we would consider differently is if they had been on estrogen-containing treatments. Of course, if they're pregnant or postpartum, then those are episodes of more secondary or provoked thrombosis. But I think the question here is, if it's unprovoked, we know that men are at higher risk of recurrence, and based on clinical decision rules, you may decide to treat men indefinitely and women for a shorter period. I think it's very individualized in my practice, at least. So I do sometimes refer to the HER2 or the DASH or the Vienna rules, prediction rules, and again, these are in Thrombosis Canada in our guides. But I do that more for teaching purposes, and individually I try to individualize management, and I typically will do a post anticoagulation D-dimer test as one way of risk stratification, but it's not a one size fits all approach, and whether either in men or in women. That's sort of my practice. Okay.
Maybe I can ask Alison another particularity. So I do what you as well, Jim, vis-a-vis, looking at, often the specific situations regarding pregnancy and oral contraceptive use. But I do find this issue that keeps coming back vis-a-vis DOAC specific risk of menstruation and having these types of situations in women who have a DVT-RP and are treated with a DOAC. And it seems to be that not every DOAC is the same when it comes to menorrhagia. So I don't know, Alison, do you have any comment on that?
So I not really.
No. Okay.
So, well, I mean, I've seen data supporting that apixaban has less menorrhagia than rivaroxaban. I know I've worked with people who report, way more women report menorrhagia while on rivaroxaban. I know there's been studies looking at DOACs, and dabigatran actually had the signal of the lowest amount of menorrhagia. I think it really depends on the patient. If they have really bad menorrhagia on one DOAC, I think it's fair to try another one. Generally speaking, like BID dosing makes sense to me, lower peaks, higher troughs. But yeah, I can't say that I'm really convinced that one DOAC is better in terms of menorrhagia than another. Yeah.
Yeah, that's my sense as well. I don't know, Jim, do you have a different sense?
I agree completely with what Alison said. A lot of what says reflects what we've seen anecdotally and now is emerging in the literature that, you know, as I said earlier, you know, DOACs are not all the same. They're not, you know, some have certain side effects that others don't. And yes, there has been apparently a signal with once a day, in this case, rivaroxaban, and you know, menstrual bleeding being exacerbated or dysfunctional uteri bleeding worsening. So I think people need to be aware of that, you know, the DOACs are not interchangeable, and that some have certain side effects that others may not have as much.
Great. And with that, we're going to be closing, I think, our session tonight because we are at the hour of almost 9 o'clock. I want to thank the audience for submitting such great questions and interesting questions, and really giving us this opportunity to have an important discussion around some of these topics with our panelists. I want to thank Dr. Easaw, Alison Bond, and Dr. Jim Douketis, my co-chair. I want the audience members to please provide us with your feedback. It's always important to help guide us in developing future sessions. Your evaluation is very important, and we have a slide up here that indicates how to click on, you know, the link that's provided to provide us with your feedback. It will be emailed to you at the end of this session. So with that, I want to thank everyone on the panel and the audience members who attended tonight, and those that did provide us with the questions. I wish you all a good evening, and thank you very much.